This week on the BackTable Podcast.
Like I noticed, like as I went through the tips and tricks, I just felt like they were like applicable, like low cost, super simple, can do them in any lab, and just came up like a fair amount. And so like those were the ones that kind of spoke to me.
I was very impressed that none of them required extremely fancy equipment. I guess a couple of them were talking about, liquid embolics and how you manage those.
I love those.
You're probably going to really like those.
I love liquid embolics.
Well, do we have a trick for you?
That's right. That's right. Ladies and gentlemen, welcome to the BackTable Podcast. Thank you for tuning in. We have a special episode. It's an all-host episode. We have Allie, Mike, myself, Sabine, Don could not make it. Family commitment. Anyway, we have the BackTable Tricks and Tips competition that should be, by the time this episode drops, coming to a close. And so we wanted to kind of just discuss some of the cases, unpack some of our favorites, and also thank everyone who's submitted a trick or a tip into the submission pool. I know that for myself, I really enjoyed watching them just as a judge. Like they were really fun to see. And as an interventional radiologist, I picked up a lot of cool stuff. So I thought this was great. All right, so let's get into it.
Did you guys submit any tips or tricks?
Mm-mm.
I was too self-conscious too. I was like, my tips and tricks are, somebody's going to look at them and be like, that's lame. Why didn't she just know that?
I actually had a hard time with it because I don't think I have any tips or tricks. I don't have any tricks.
Come on, you don't have
I have
single...
tips. I have tips. I don't think I have any tricks. I just have the way. Like I just,
Yeah.
It's like, this is my special technique for forming a coil that doesn't shoot down the SMA. Like I have an algorithm for certain things, but like, I don't think I have any special tricks. I think it's probably just because I'm doing things so well that I don't need tricks.
You don't need tricks when you're the
It.
best.
Yeah.
Yeah.
So I didn't submit any. I felt a little bit self-conscious about it also. And so that's why I just wanted to commend everyone who did like throw in their submission. I thought that was awesome. And also it's a time commitment. I did have two. I'll talk about like if I were to record one. This is actually why I wanted to record the show. One, because I thought it was a resounding success. Like people submitted, I thought they're great. I think people are going to watch them and think this is cool. And then I think when we do it next year, I think a lot of people are going to see like the bar is already set and everyone's going to be like, yeah, I think I got something. And then I hope like people record it like periodically through the year and just save it for next summer. And then we'll put it on. So I hope that's really what happens.
Yeah. I mean, it doesn't have to be like extreme IR. It could just be like,
No.
See, that's what it wasn't. It was not extreme IR.
It's unextreme IR. Yes.
Yeah, it was unextreme. There was one extreme. There was like one or two extreme.
The other thing that was cool, Chris, was I loved how it wasn't just like academic people sending in trips. It was like regular interventional radiologists and cardiologists sending stuff in too, and not like, oh, this is some crazy case and here's what I would do in this. It was like, oh, this is what I do every single day for this specific type of case.
Totally agree. And then we had to judge them. I forgot the criteria of which we judged them, but one of those was like everyday use. Like, do you use it in every day? Yes. And so I thought that was like a good criteria for which to judge these things. All right, so we'll get into it. So full disclosure for the audience, Michael has not seen a single one of these.
He's raw dogging it.
He'll be learning along with us. All right, so for starters, Allie, what was your favorite?
Oh my gosh. Oh, I'm so sad that you asked me that question because every time I watched one, I was like, oh my God, yes, this is the best.
Mm-hmm.
And they just kept getting better and better the more that I watched. Okay, let me think. Which one do I think Mike would like really want to see first? Let's start with a basic one.
Okay.
Show the Aaron Fischman question mark one.
Everybody that works with me knows that this is my favorite shape. It's not as dramatic as I guess it sometimes is, but I call this the question mark. And I think for prostate embolization, giving a little back curve on the wire along with the tip curve gives us the best chance, specifically if you're not using an angled microcatheter, to get into those really angulated type 1 vessels. And so that's the curve that we use. This is an 016 wire.
Dude.
Thoughts?
I think it's awesome. I'm going to try it. Now, the only thing I wish is to show me exactly how to make it, but I think I have an idea. I'm thinking about my Fathom, which I use every day. I'm actually going to use this. The guy has done a couple prostate embolizations.
I'm going to try it on my case this week. Yeah. And I feel like when I learned how to do or like make a basic shape on a wire, it never had that back curve. And that was like always a second choice. Like if the first one doesn't work, add a little thing to it. But I like that he kind of just like starts out with that. I'm going to give it a shot.
So I'll say, I'm sure if Aaron Fischman is watching this, he's like, wow, what a chump. But I'm sure he does these all the time. But like, actually, so also just start out with just a regular curve. And then if I can't get into something, that's like one of the things I'll go to fairly quick is like the little back bend on it. So start out with a regular curve and then I put the back bend on it. But if you kind of just go too fast and you're just like, oh, I'm just going to throw that back bend on it, you'll put it at the wrong angle. Instead of it being in the same plane, you just have this curve and then it's now just curved to like the left or the right.
It's like a corkscrew.
And I'm like, yeah, exactly. And so his was like clearly perfect, like all in the same plane, like a little cobra. And I just know that like when I've done it, I'm like, all right, we need a new wire. This is not getting in anything. It's not going to get back into the catheter when I do it. All right, I like that one. Here, I want to show Mike this one. Boom, boom, boom. Get off of that. All right, here we go. This was one of my favorites. Dr. Sean Maratto making your own snare with a Benson wire.
This is Sean Maratto here from Jefferson, Northeast and outside of Philadelphia, Pennsylvania. And this is my submission to BackTable Tricks competition. So in our practice, we take care of a lot of urology patients where we are required to place double J stents from a retrograde approach. The patients typically already have an open-ended ureteral catheter from urology being unsuccessful to get past the stone or being unsuccessful to pass a double J stent. And unfortunately, we don't do these very frequently. So sometimes when we place the stent, we put it in too far and the pigtail gets pushed into the ureter and hanging out into the bladder. So I have Megan here, one of the RTs from my department, to assist me in this procedure because we don't have an actual patient to show you the technique. But typically in the bladder, there is a lot of space. So the initial thought to retrieve the stent would be, hey, let's put a loop snare in and try and grab the pigtail and pull it down. The problem is the bladder gets so capacious because it's full of urine and fluid or contrast that the snare doesn't quite make the reach. So in residency, I was taught this trick utilizing two simple items, a 7 or 8 French sheath. Today we have an 8 French sheaths because we don't have 7s on the shelf right now, and an 035 Benson wire. The initial step would be to obviously prep the sheath and put it retrograde through the urethra. Megan's going to hold the sheath for us when we're ready. And then we're going to take the Benson wire out. Doesn't matter which end you take out first or use. You're going to actually kink purposefully the Benson wire and advance it through the edge of the sheath with the kink. Once through the sheath, you pin one side of the Benson and push the other side. And what it does is creates a modified loop snare. And as you push this out, it widens the snare. And what you're going to do is pull and push with the non-kink side to open and close the snare. Eventually, after multiple attempts, you'll grab the pigtail and then pull the whole thing into the snare to control it and pull down. Okay, so now we have a fluoro.
Come on, and then he just shows him actually like putting that into use. Like he just snares that like catheter that's on the table using the like that modified loop snare technique.
Have you ever seen that before, Mike?
Yes. So I learned that from Scott Chertola at Penn. That's how we removed ureteral stent, and it works so well.
Had you seen that before, Allie?
No, but I love it. It's so practical. It's inexpensive. I can do it at any hospital that I would go work in and not have to worry about, oh, do I have this on the shelf? And yeah, very, very useful. I think hardest part is going to be get access into the bladder, to be honest.
I'm glad to know that I can do it with the Benson. I've been too scared to do it ever since the first time that I tried it. And
I get that.
Yeah.
So I'll say, actually, I have no idea. I mean, I have a little bit of an idea, like the situations that they're talking about using it. Like he's saying that they have access into the bladder through like a penile catheter that urology has left, but they're putting up the double J stents retrograde, and it sounds like they just misdeploy it and they're snaring it. Is that right? Is that how you understood it?
I thought like maybe he's doing like he did a conversion from like a NUS to a double J, and then it wasn't measured correctly, and then it flopped down and he had to grab it and do it again. That's what I understood.
That's what I assumed. And then when I listened to like the scenario in which they use it, which isn't that important. Like to me, the important thing is like you can use that anytime you just want a big fat snare. Like I actually could see myself like urology asks us all the time to do this. So like, hey, drop a double J or no, not drop a double J, but they're like, exchange like your catheter and then like snare ours like on the way out. And like sometimes it's nothing, and then sometimes it turns out to like a total war. And actually, on a couple of occasions, like for whatever reason, the double J is like stuck like in the highest calyx imaginable, and like it's just the angles don't want to work out for it. And so I'll just get into the bladder and fish around with the snare until I can grab it. And so, I mean, I could get like a long sheath down. I mean, I don't know, maybe it depends on like what that ureter looks like, but I don't know. I could see a lot of situations where I would use this and just like fish something out. I love this.
Can you show the tips one? The tips one was so good.
Right. Really, like we were picking. Hold on. Let's take a break before I show Tyler. So here's what I realized, like once I watched all these, that like I just had the bar set in my head at like I have to have like the coolest tip ever that's gonna just like blow everyone away. And not to say that these were great, but I just thought I was like, oh, I actually have something I could share here that I think was a cool trick. Do you know what you would share, Allie?
I'm at a disadvantage because my C-arm that I bought does not have store fluoro. And I think that is a killer for me because I can't 100%. Like if I do something and I'm like, oh, I wish I could save that and show that, I just can't. And so what I like, if you're doing antegrade access for a leg and you accidentally get into the profunda, which happens like all the time, how do you switch it and then get it into the SFA? And I learned it from Mary Constantino, and I use it all the time. It's basically just using a rim catheter to switch to get into the SFA, or a mini rim. Or just doing this one thing where you basically do like roadmap and then pull back your wire with a curve on it and redirect it. So like nothing that's rocket science, right? But I use it all the time. And it's a situation where if I didn't know that trick, it would take me way longer to do these cases.
Did you see Hattie Lika's? He had like where like you take the short like kit wire or the short sheath wire.
That wasn't Hattie. That was somebody else.
Oh, that was somebody else?
Yeah,
okay.
But that one was good. But I think that person doesn't use a micropuncture. They just go in with an 18 gauge.
I think you're right. Yeah. And he does it under ultrasound too.
That's how Steve Young and Russell Bacon used to do. They used to basically call me for using a micropuncture wire, Steve and Russell.
Really?
Yeah. They would just go straight with an 18 gauge and an Amplats.
Wow.
I'll access with an 18 every now and then, like for, I don't know, I can't think of the reason. Sometimes if I get just like, it's just like a chip shot and I'm just ready to roll.
They would call me up for using a micropuncture, and two of my current partners call me up for using ultrasound. And so it's like,
okay, who thinks that you're for using ultrasound? I got to know.
Majoria and Schuber. They're like adamant about it. It's especially Majoria. Majoria is like super old school.
Yeah. I get it that like people, like my first like 5 years, I was still accessing, just like palpating it. And I was just like, and like, it's fine. But like, I don't know, like if the probes now, like the techs just have them and they're prepped and I'm like, yeah, let's do it. But maybe, well, I'd be a wimp too. So whatever, Michael. So if you had to put a tip out, what would you put?
So it's actually Majoria's way of doing a gastrostomy tube. So he puts instead of putting an NG tube down, he puts a catheter in through the mouth into the stomach and then exchanges that for a 9-French sheath. Then he puts a snare through the sheath. So you just stick a needle he fills up the stomach with air. Then you just stick the needle from the front into the sheath and you snare a wire that you put through there, pull the wire out through the mouth, and then hook up the tube from there and then just pull it all the way through. It sounds complicated. It takes about 2 minutes.
What?
That's a good way. That's how awesome. One of my attendings used to put in. So do you have a different type of tube that you're pulling? You pull like the disc ones?
The ones from GI, like the actual peg tube.
Yeah. That is a pretty
So you just pull it through the mouth. So you have from the mouth all the way through, and then you just hook it up and pull it through, and it's so easy. And it's kind of fun because anytime you get to use a snare and catch something is fun.
All right, so one of the things, like I'll credit Chris Barron, and I can't even get this trick ever since like I came down to New Orleans. I can't get this trick to work like reliably. But did Barron ever show you like cutting up gel foam? So you cut it up on just like a little plastic, whatever comes in your cath lab pack, but not on like a blue towel or something. So you just cut up your gel foam and you have like all the little gel foams sitting there. And if you just take a little medallion, like the static electricity from the medallion will just suck up all the gel foam like kidding? Magic. Oh no, it's so nice.
Do that trick next year. I will love that.
I remember like I was like a fellow in Phil Banavac as usual shitting on me about something. I was like, look, let me just show you how like I suck up this gel foam. He's like, no. And like as I'm doing it, he's talking about it and telling me how stupid it is. And then like it happened and he stopped running his mouth and he was like, oh, that was cool. And I was like, yeah,
that's
like that was good. The other thing I do sometimes, it was at Penn. I don't know if you guys ever did this, like the bumper stitch.
Yeah.
What's that?
I like the bumper stitch.
What do you mean?
Have you ever?
Haven't done one since Penn.
I'll do it every now and then. Like, I would actually love to have a podcast on like tubology. Just like, what do you do for all those things? Like with a tube that's constantly getting pulled out.
That's a brilliant idea.
Yes.
The leaking tube, the tube that's always falling out. And so like once like the tube, like that, whatever tube it is like fallen out for the 100th time, I'll usually try and upgrade it to the biggest like size possible. So I'm upgrading the pigtail. After that, I'll do a bumper stitch. So the bumper stitch is like, what'd you call it? Like a reverse mattress. And then like on one of the stitches, you thread in like
you throw like a big piece of tubing, like you cut a piece from like a gravity bag, and then you suture from one of the entry, like from one of the edges of the suture, from the edges of the incision out. And then you pull that out, then thread it, and then thread it back in. So yeah, it is kind of like a mattress.
Yeah. And on the part of your mattress that's like, but on your like mattress that like with the stitch that's like hanging out, that's where like you put your tubing. And I don't know if that's the sauce, because like by the time I'm doing that, like, so I do the bumper stitch, which I like, and then I'll put them in like, if it's like a Neff tube, I'll be like, put them in a soft binder, like an abdominal binder. So like they don't get pulled out during transfers. And, it's not, look, that's not like life-changing advice for anybody, but like if you're having a tube that's always coming back and you can get it to last like 4 weeks instead of like 4 days, that's a win.
Yeah.
Can you take a picture of that and send it to me the next time you do it? That sounds sounds
sure.
very useful. Oh, this all started with us talking about tips. Yeah.
Tyler Sandow, Interventional Radiologist at Ochsner Health. Because I'm dying to get another one of those BackTable hats, I'm going to increase the number of missions that I do for this.
Tyler has every piece of swag that BackTable has, by the way.
Way more than me.
Tip for tips.
I don't have anything.
Now, I know ice is all the rage these days, but I'm going to show you an old school technique that's worked with 100% success for us at Ochsner over the last 5 years. And it's direct portal access.
Yes.
We use ultrasound guidance to insert a 21 gauge Chiba needle into whatever portal vein branch we choose to select it. We think will give us the most favorable access for the tips down the road. Once we've obtained portal venous access, we'll insert a guide wire from the AccuStick set, followed by the inner portion of the AccuStick system, and then do a direct portal run. When we're satisfied with our portal access, we'll insert the nitrix wire, an 018 nitrix wire. We use the radiopaque tip to give us a good target for where we would want to access the portal vein with whatever tips needle you would choose. In our case, we like to use the Colapinta needle, which you can see here. And then we'll just use it to steer directly onto the radiopaque portion of the wire where we'd like to hit it. And this is us completing that portion of the tips here. As you can see, we stuck the portal vein exactly where we wanted to. There's good flow in the portal system, and now we can move on with completing the tips. Although the wire went forward in the portal vein, we can still get a 4 French angle catheter and redirect it how we'd like to go down the portal system so we can appropriately lay the tips. Again, I like to think of this as adding 5 extra minutes to the case to solve for hours and hours of frustration down the road. This is the setup I like to use. Again, it takes about 5 minutes. I scan and prep the right upper quadrant prior to having the tech prep the neck for the case. We start with direct portal access under ultrasound guidance. We'll advance a wire in the inner of an AccuStick into the portal venous system, do a gentle portal run. Then we'll put the radiopaque portion of the nitrix wire where we would like to access the portal vein for the tips. We lock the wire with the inner introducer in place on a flow switch and then lay the wire and catheter on the patient. Then we move to the neck and get rolling. Here's another case where we applied the same technique. Obviously, this is going to be a much more challenging case because this patient had Budd-Chiari, but we were even able to get into a gentle aspect or a central aspect of the hepatic vein and then try to stay intrahepatic to access one of his very, very small portal vein branches. His right portal vein was incredibly small, but we felt that gave us the best opportunity to give him the tips, but maintain portal flow to the remainder of his liver. As you can see here, we use RAO projections to help us guide or know whether or not we're anterior or posterior to the site we need to target, and then we can redirect our needle appropriately. Now, this was a real challenging case, and even though we stuck the wire and got access into the portal vein, where we were within that portal vein, because it was so small, it didn't allow the wire to travel down into the main portal vein so we could set up the tips. So with minimal retraction and redirection, we were able to kind of steer more centrally to the portal vein, which you'll see here, and then again stick directly on the wire to get good access into the portal vein. And I think this shows another good use or utilization of direct portal access using a radiopaque wire for your tips. And, replacing cases where you may not necessarily need to use ice or may not have ice available to you. One more case, again, showing the same technique with the radiopaque wire and using RAO to identify whether or not we're anterior posterior. See, the needle was slightly anterior in that case. So rather than trying to turn your needle more anterior, knowing that you're going to miss the portal vein, we actually moved the needle a little more lateral and you can see you're directly puncturing on the wire.
That
and you
is
can see it pop
so
in.
gratifying watching him hit that wire.
And here we are directly in the portal vein, exactly where we want it to be.
Yeah, you are.
Now, I don't know if you could tell, but that liver looked as hard as a rock as the needle was trying to advance.
I like this part because
you can
I
see
do
these
this.
angles are not favorable.
Yeah.
So I'm going to throw a second little pro tip in here for people that have challenging livers where it's hard to advance your sheath through the system. Now, obviously, everyone has tried to balloon the track.
Oh, I know where we're going here.
Introducer from the sheath.
Yes.
Hold on. Where is he going?
I think he's going to put the tips needle in through the sheath and advance over the tips needle. That would have been my trick.
Oh,
yeah. Well, he already got it. He already got it.
Oh, it's like my favorite move.
It feels
so
baller.
sweet. It's like we have this head tech, this lead tech who knows everything. He's like, the guy asked for everything. Like, what size sheath? What size stent do I need for this? I did it in a case, and it was like, holy shit! Like, wow.
It impressed him.
That's good.
Or he taught it.
Yes, yeah. It's the only time I've ever done it. Yeah.
Oh my gosh. Yeah.
Yeah. All right. So here goes.
Turquoise wire. Well, even in some techniques where that's obviously not going to work, you can see it was hard to even advance a simple balloon across the track. What you can do is after ballooning your tract and using all these other techniques, you can actually use the colapinto needle, which needs to stay covered, and you slide it along the wire, and then the sheath will gently advance over that system into the portal vein, which is what we did here. Unfortunately, my tech didn't save the floor run showing it, so I couldn't use it for this demonstration. Now, after all that, you're home free, and this is another good example showing the use of direct portal access and the radiopaque portion of your wire for where you want to stick in the portal vein. I'll add this. It's always easy to remove the 3-French introducer of the AccuStick system, and the wire. I've had no issues even after completing a TIPS with removing that. We've had a 100% success rate using this technique, and I hope you found this helpful if you didn't know it already. Thanks to BackTable for putting this kind of contest and opportunity to share techniques with colleagues across the country. Look forward to seeing everybody else's, and thank you guys.
Yeah. So that was super good, right?
That was so good.
And then he kind of just handles it afterwards. He's like, yeah, and if you were worried about that, like AccuStick, like the inner to that, he's like, don't worry, just pull that. That's fine. Yeah,
I like this because I hate doing a CO2 portal venogram.
I just switched to ice, so I kind of stopped doing it.
I haven't done it. I do the full like 2 passes anterior, 2 passes posterior. Then we'll do a venogram, but I like his way better.
Hold on. So when you say do a venogram, like you're doing a CO2 venogram?
But only after I've done a few passes.
Yeah. I think that's fine. I mean, CO2 is good too, but the direct stick that's kind of nice. I mean, cool. I think like it's just, to me, it's one of those things. I actually haven't done it, but it's crossed my mind, and because no one ever showed it to me or said, Chris, you should be sticking the portal vein, I just thought like, it's probably a bad idea to like stick the portal and like, put any access in there. Like I just needed someone to tell me, hey, Chris, that's okay. You can do that. And now Tyler Sandow has. So now I feel great.
I'm really glad you talked about closing the tract though, because like if you've ever had to do direct portal access for anything to embolize or anything, that is the hardest part of the case, is like making sure that you close that tract appropriately. Do you do a lot of radial access, Mike?
Not anymore.
Hold on. Why do you say that?
I just don't like it very much. I do it sometimes. Yeah. I'm like, so I work at a place where it could be a challenge to do radial access. They just make it very difficult for me. It takes a while to set up, and I do it when I need to. I do it for stroke cases sometimes. Other issues with femoral access on occasion, I'll do it. Or if I'm going to do like a PAE or a UFE and somebody specifically requests it, then I will do it. But I have in the last couple of years changed to being mostly a femoralist. I'm not against it. I like it. It's just for me, it's a logistical thing most of the time.
I do all my UFEs radial, and then I'd say I do like 50% of my prostates radial as long as they're not over 6 feet tall. I just think the angles are easier. And then hemorrhoids, I do radial too, just because it's pretty easy to get in the IMA that way, I enjoy good femoral access case as well. In the main place I work, we have time constraints for how long you can keep somebody after.
Okay, sure.
So this really helps with that. And I have stuck the ulnar artery before if their radial was too small to do it. But I've never seen this trick that Hottie sent out. But I think it's fantastic, because if you've ever had to deal with a radial artery or an ulnar artery occlusion, you know how awful you feel, how awful the patient feels. The fact that, okay, I feel like I'm giving it away. Just show the trick. It's good. It's good.
All right, sorry.
Yeah.
I wanted to also say, for like anyone who's like, I think there are a lot of like radial and femoralists. For me, like some of the older crowd has like, I've heard them like dog radial. Like, if you don't want to do radial all the time, that's fine. But I just don't like people who like tell you like how terrible radial is and how it doesn't have any place and how it's dangerous. I'm like, oh, do you know how to do it? And they're like, no. I'm like, well, like, don't couch like how dangerous it is and the fact that like you just don't do it, right? Like, if like you prefer not to do it, I think it just needs to be another tool in someone's tool belt. Like, I don't like to hate on radial. I like to like on radial.
You don't like to hate on anything though. That's what I love.
I don't like to hate on it.
Interventional cardiovascular specialist presenting tips of ulnar artery access. As you see, the ulnar nerve here has to be identified and avoided, not only painful, but causes a lot of long-term neurological side effects. Ultrasound is definitely key. Anterior stick as distal as possible, 60-degree angle, the smallest sheath to do the job, and preferably braided sheath to avoid kinking. The same band used for the radial, you flip it, and you use obviously 15 units per kilo of heparin. We monitor carefully since this is an access that has a high risk of bleeding. Now, what happens if you have an occlusion on the table? This is a case where we deflated the TR band to 0 and the ulnar artery was completely occluded. And we did an ultrasound on the table, which I highly recommend. And at this point, we confirmed the absence of flow. We did the preferential perfusion by compressing the radial artery while monitoring the oxygen platelet on the pinky finger. As you see here, this definitely works. And you can see the ultrasound, the artery is closed in diastole, but it actually opens up in systole.
Isn't that wild?
Mm-hmm.
Yeah.
Yeah.
So doing the ultrasound yourself is definitely very helpful. And obviously we can give additional heparin. Another tip is also to place nitroglycerin on the area that's perfused by the ulnar artery.
Who figured that out?
That's nice, right?
It's really nice having more participation from cardiologists and vascular surgeons too, because we just look at things very differently. And, you know, they're doing that every day. And I just think you see ideas and just routine techniques for these people that I'm like, whoa, like that, never thought about that. That's really cool.
That's a good one. I like that one too. So I was like, I noticed like as I went through the cases, I had a propensity to like the cases that were, or the tips and tricks that were, I just felt like they were like applicable, like low cost, super simple, can do them in any lab, and just came up like a fair amount. And so like those were the ones that kind of spoke to me. Allie, which ones did you like?
I was very impressed that none of them required extremely fancy equipment. I guess a couple of them we're talking about, you know, liquid embolics and how you manage those.
I love those.
You're probably going to really like those.
I love liquid embolics.
Well, do we have a trick for you?
That's right. Sandow had another good one with, his is actually not really about liquid. Well, it was the case that he was demonstrating it was, but basically it was a case where, like, I'll just describe it. I won't play it so we can't give him like double duty, but like basically like you get into the vessel that you want to embolize, you do a blank roadmap. So you white out the screen. And then whenever you're injecting your liquid embolic, which should opacify, anything that shows up black, you know that like you've embolized that territory, and you can move on to the next one. Yeah. So, you know, by the end of it, like you it's really sensitive, like to pick up any reflux, and like if you're going anywhere that you don't want to be, or when you're done embolizing whatever vessel you want to be done with. So that was pretty cool. I'm excited because I think this is going to, like you said, give people, oh, I can do this too. And then they're going to try these tricks out. They're going to have their own tricks. We're going to get crazy submissions. I think it's going to be pretty good. Yeah, I agree. So, all right. So anything else? Final thoughts on the BackTable tricks and tips competition? Allie?
Mike, I'm excited to hear from you after you finish watching them all, what your favorite was. Yeah, I watched them all, but I haven't done the rubric yet to do all the voting, so I'll get to watch them all again. But yeah, kudos to everyone who sent something in. It takes a lot to put yourself out there, and then just to take the time to put something together, that's a big task.
Mike?
I agree. It's just awesome. Thank you to everybody for doing this. I'm also excited to know that I have some tricks. I didn't think I had any tricks, and just from talking to you guys.
I mean, I don't know, like if you put the same call out to action to like other specialties, if they would like, you know, come in with like, I think we have like 10 or 12 submissions. And so like, I'm always like it warms my heart to like know that like the people who like listen to BackTable, like they're into this stuff. Like I think there's going to be a whole bunch of people who are going to watch these and be like, oh yeah, next year, game on.
Yeah.
And then for the people who did submit for like year one, like, you know, the pilot program, you know, big thank you. Like Ali said, it's not lost on us that like Like it was an effort, you put it out there, and just to like be clear, like for anyone who's ever been on BackTable as a guest, like or is ever interested in coming on BackTable, like the show's nothing, like the BackTable tips and tricks competition, like it isn't anything without like the audience participation. Like without the guests, like I had a guest come on, he was like, oh, thank you so much for like letting me come on. I was like, what is this podcast without you, man? I was like, the podcast is nothing without you. So thank you to our audience. That's all I can say. All right, guys, we'll see you next time on the BackTable Podcast.
See ya.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Baheti,
Michael Barraza, Sabine Dond, and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.